Okay, so what are the advantages under the ultrasound? First of all, you did not take the patient to the OT. You can do it in the ward. That is the one of the biggest advantage. No chance of radiation exposure. Then there is another big advantage, especially for the malignant patient. Sometimes this patient is having ascites and sometimes they have painful abdomen. So making these patients prone sometimes becomes very, very difficult. Whereas in the ultrasound guided procedure, you can do in the supine position. But problem is definitely there with the ultrasound guided procedure because what happens in celiac plexus, sometimes in the abdomen is not clear, the bowel is not clear because transverse colon is running just in front of it. If there are a lot of stool and gas shadows, sometimes you won't be able to see structure. And that happens quite a lot. That is why in most of the patients, we do a bowel preparation before doing these blocks under the ultrasound guidance. Both the blocks. Because in that case, our visualization becomes good. Number two, in these procedures, you have to invariably puncture one or more organ. For example, if celiac plexus block you are doing, so either you can put the needle through the liver or you can put the needle through the stomach. So in both the cases, there are chance of you have to puncture the liver. There are chances of infection, especially while doing the gut puncture, the chances of infection are more. That is why routinely we give a prophylactic antibiotic in these patients as well. And here another important thing is also there for the celiac plexus to reload the patient because what is happens after the block, as it is a sympathetic block, so there will be parasympathetic overactivity just following the block, and there will be a little bit hypotension. So check the blood pressure even during the procedure. That is independent of the which technique you are doing, whether it's fluoroscopy or another ultrasound. But this is happening in both the cases. So let's first go for the anatomy related to the ultrasound. But before that, indications of the celiac plexus that we all know. One is definitely the malignancies. That is the most common indication. Upper abdominal cancers, and then is chronic pancreatitis. And grade of evidence in to be in case of pancreatitis. Now we all know there are three splanchnic nerves, Richard, Lissa, List. So what are those splanchnic nerves? These are preganglionic fibers from the following root. This T5 to T9 forming the greater splanchnic nerve. T9 to T11, sometimes it is called as T10 and 11. They are forming the lesser splanchnic nerve, and list is formed by T12 or sometimes T11 and T12. So these preganglionic fibers, instead of relaying in the ganglion, sympathetic ganglion, they continue. In this area, they run along by the sides of the T11 and T12 vertebra. When it pierces the cracks of the diaphragm, then it comes to anterior part of the aorta, and here they form celiac ganglion or celiac plexus. That the preganglionic fibers are actually communicating with the postganglionic fibers, and then they are continued to the respective organs. And some fibers descend down and they form the superior mesenteric ganglion. And here they are the areas from where upper abdominal pain are mainly carried through this nerve. How we can block it? One way of blocking is at the back when we are at the splanchnic nerve level. So we can block by the side of the T11 and T12. This is known as the splanchnic nerve block. Or if you are slightly anterior, the same concept is known as the retrocaudal celiac plexus block. Whatever is there, we are putting neurolytic at this point. Under the ultrasound guidance, the technique we employ is known as antecaudal celiac plexus block. That means in front of the aorta, we will be putting the drug close to the bifurcation of the celiac trunk. Remember, celiac trunk is the first vertical branch, mainly which is coming from the aorta, and they divides into three branches. Grew larger. One is the common hepatic artery towards the right. One is the splenic artery towards the left, and there is a left gastric artery. That's a very small artery. that is also a branch of the celiac trunk. But what we search for is mainly the bifurcation of the celiac trunk into the common hepatic artery and splenic artery. To find out, we start scanning from the xiphi. We try to locate the aorta in front of the vertebra. Now, as we locate the vertebra, we gradually tilt the probe towards the caudal side. So from here, we will be start scanning. And once we get to see that gush of blood moving forward, we can think this is the celiac trunk, and they divides into two branches. Okay. So how it will look, I will come later. So here, when I am putting the probe like this, the probe is put like this, okay, in front of it. So it will appear when the blood is moving like this. It means this is the celiac artery, sorry, this is the abdominal aorta under the ultrasound, from where the celiac trunk is moving up, and then it divides into two branches. One branch towards the right side, this is the common hepatic, and other branch is towards the left side, this is the splenic artery. Now, this is known as the seagull sign because this appearance under the ultrasound looks like a flying seagull. Okay? So this is also known as seagull sign. We always remember while doing the celiac plexus block. Remember, it is not essential to put exactly the drag here because you can understand and see the ganglion is not a small like ganglia. It is covering large area. We have to give at least 15 ml of drug, even if we are going from the anterior side, cover more area. That is the reason we cannot block the celiac plexus with the help of radio frequency. Radio frequency is a very limited size lesion, 2 to 4 millimeter. And here we require a comparatively larger size lesion. So here we always have to do a radio frequency. Instead of radio frequency ablation, we have to do a chemical neurolysis. So what are the chemical neurolytic agents commonly used? Definitely, first of all, alcohol and phenol. They are most commonly used chemical neurolytic at this point. Usually, concentration of alcohol between 70 to 90% commonly given. Remember, while giving alcohol, you have to give prior local anesthetic. That is why we prefer approximately 90 to 100% of alcohol because before we have to give 5 ml of the local anesthetic. Otherwise, alcohol produces a lot of burning sensation and discomfort to the patient. First, we have to give local anesthetic. Then we can inject alcohol, and then we have to inject a very small amount of the local anesthetic or sometimes a normal saline and then take out the needle because we do not want the tract that is formed that should be having the alcohol. Alcohol should come out to the tract. Little bit fluid is injected and then it is taken out. So that is the technique moreover, but let's see how under ultrasound we have to see it. So these techniques I have already told about the slide. When we are doing from the posterior side, it is known as the retrocrural. When we are doing from the anterior side, this is known as the anticrural. And whenever we are close to the splanchnic nerve, this is known as splanchnic type block. Ultimately, they are blocking to the same nerve but at different locations. Now, under the ultrasound, these are the structures that we see here. So, in the right side, we'll be able to see the liver, and just behind, we'll be able to see the aorta and the celiac trunk, and in one side, it will be the stomach. We have to go to this chart here to find out that area. So, initial scanning starts from the xiphi and then we'll gradually put probe down and we try to figure out this condition. That means here you can see this is the vertebra. So whenever first you are putting, you may not be able to understand which vertebra is this. We know celiac trunk corresponds to L1, but there is no way under ultrasound to look at and find out that this is L1. You cannot say that unless and until you are seeing the celiac trunk. So in front, we see two vessels. This is the artery and this is the vein. So how to differentiate between the artery and vein? The simple thing, number one, movement and pulsation, and number two, just to with the probe. So what will happen? The vein will IVC will blanch, but this will remain pulsating. In that way, you can differentiate this aorta from the IVC. Now, from there, you try moving up and down the probe. Okay. So once you start seeing this is the IVC lever and this is the aorta, and longitudinal orientation I am coming later. Once we start moving, then what happens? We'll be able to see this picture. That means from the celiac sorry, from aorta, there is a gush of blood which is moving up, then it is going to the left and right. The left side is the common hepatic artery, right side it is the splenic artery. Remember, sometimes getting this picture becomes a little bit difficult. And so what we do, we try to see it in a longitudinal view. So in the longitudinal view, it looks like this. So under longitudinal view, we'll be
Yes.
seeing this is the aorta. This is the aorta. And this is the superior mesenteric artery. And this is the celiac trunk. Okay. In that case, you will not be able to see the bifurcation as you are looking from the center. But remember, this clean picture is only possible when you have prepared the bowel well by giving positive on the acids. So in volunteers, in most of the cases, we get in the evening a loaded stool, loaded colon here. So there is a big acoustic shadow. Stool and gas is there, so there is a big and acoustic shadow. But anyway, even though we have to see the structure, okay. Now move to the, so this is the thing, and this is the seagull sign, the short axis view of it. This is the seagull sign of that structure. And by seeing short axis and long axis view, once you are confirmed, then where you will be injecting, either you can inject at the top of the seagull, that is recommended, or what you can do, from the seagull, you can move slightly up and you can inject in front of the aorta because that is the area where the celiac plexus remains. Okay, in that way, you can inject. Okay, and when you are putting the Doppler on, you can see this view. This actually shows the aorta, celiac trunk, and as well as the bifurcation of the celiac trunk into two branches. And long axis view, you can give color and you can check this view, but structures will be remaining the same. You'll be able to see the colors. Complications, there are chances of the bleeding, retroperitoneal hematoma, perforation, pneumothorax, chylothorax, impotence, paraplegia, intravascular injection, infection, thrombosis or embolism. Injection to the epidural area, though if you are not giving it properly under guidance, the chances are very less, but it can happen. Hypotension always happens. That is why you have to little bit of fluid before, and sometimes the patient might have diarrhea as well. Okay, the reason behind the reason is the same. That is the parasympathetic overactivity. In most of the cases, it is self-limiting. In some cases, you can give diphenhydramine atropine, or sometimes you have to give treatment for the diarrhea. But in most of the cases, that is not required. Coming to the superior hypogastric plexus block. This is another sympathetic block that is mostly done for the pain in the pelvic. So what is the origin? So pain originating from the bladder to urethra, uterus, vulva, vagina, prostate, penis, testis, rectum, descending colon, perineum, and pain secondary to the cancer, which is metastasized to the pelvis, or sometimes endometriosis, sometimes radiation injury, interstitial cystitis. So basically, most common causes of the chronic pelvic pain we can treat with the help of this block, superior hypogastric plexus block. Superior hypogastric plexus is actually the continuation of the nerve fibers from which is originating from the celiac and aortic ganglion. So from there, this hypogastric nerve continues build, and in the front of the lower part of the vertebral body of the L5, the whole of the L5 is one disc and upper part of the vertebral body of the S1, it forms the superior hypogastric plexus, from which hypogastric nerve continues, and then it continues within the pelvic organs as the inferior hypogastric plexus. But blocking the inferior hypogastric plexus is very difficult, and it is within the organ. The superior hypogastric plexus is located at a definite area in front of the L5, so it can be easily targeted. So here under the ultrasound, it is targeted again from anterior side, either left or right. So in both the cases, you will be piercing the iliac loop. And here, how to do? Find out your location by seeing the bifurcation of the aorta. Because we know just before L5, the aorta bifurcates into its two iliac branches, and also both the tributaries of the IBC. This is the common iliac veins, left and right, they join just below. So we have to find out the fifth lumbar vertebra by looking at the bifurcation. Once we are getting the bifurcation, we should move slightly further down over the fifth lumbar vertebra, where in both the sides we will be able to see the aorta. From aorta, the branches of the aorta, and you have to, from by the needle, this is the needle picture, you have to go just in front of L5 vertebral body and then inject the local anesthetic and steroid for the diagnostic gain. For the most of the cases, what we do, the neurolytic block, usually 15 to 20 ml of neurolytic agent is injected in front of the L5. Okay. It is also a very effective procedure, either drug injected, either 6% phenol or 90 to 100% of alcohol. Definitely, initially, again, before the alcohol, we have to follow the same thing. You have to inject 5 ml of the local anesthetic, usually, what the lignocaine is injected. To the complications, here also there are chances of the bleeding, especially into the retroperitoneal space. Nerve injury or paralysis may occur in case you have missed the area and you have gone to the nerve root. Puncture of the surrounding organs might happen, and puncture of the adjacent vessels and distal ischemia is also possible. They are rare usually. So here one point to remember, always try to avoid this vessel. Try it go a little below, because just after the bifurcation, it means the left common iliac vein, which changes from the side from the left to right, and then the forms the IVC. So we have to go slightly below in front of the L5 at this point, and then you have to inject. Okay. So that much in the theoretical part. Now we'll be going for the demonstration of these two procedures. Yes. Hello, am I audible? হ্যালো, তোমার না আওয়াজ বন্ধ করা কি?
We can hear
হ্যালো,
you, sir.
ওকে
Yes, we
ফাইন,
can hear you.
ওকে ফাইন. So here for the celiac plexus block, we'll take this probe. That is the curvilinear probe, because here we have to see in a depth. So we'll take the curvilinear probe here instead of the linear probe. Now I am keeping the index marker. This is the index marker. I'll be keeping towards the right side of the patient. This is the right side of the patient. This is the left side. So in this area, we are expecting the hepatic tissues, and in this area, we will be seeing the stomach. So let's switch off the color and try to see what we can see from the Ziffy sternum. Okay. So as we are putting the probe, we can see the aorta. Okay. So in one side, you can see some gas shadows, but from the center, with the respiration coming, you can see the aorta. So let's try to stop here. Okay. So which structure is the aorta? This is the aorta. Okay. Everyone can appreciate the aorta with the pulsation, and just by the side, here lying the IVC. Okay. And these are the hepatic tissues above. So here in this position, we can see the aorta. That is the first point. Locate the aorta. Once aorta is located, next step is to move. Now the question is whether I can take slide simply down or I can rotate. Usually in most of the cases, if there are some gas shadows in the stomach, so we can see in one side there is gas shadow from the stomach, so we have to avoid that. Now again shadow from the colon. Okay. So if there are too much shadows, what we can do, we can add from the same point, we can slightly move down. Okay. It's close to this point, but it is not easy to appreciate today. मुश्किल है होता है और एकदम so it not clear. Anyway, let me try in a longitudinal view how much I can able to appreciate. Okay, so in the longitudinal view, we can see the aorta, but then again in front there is a big shadow of the colon obscuring all the views, and a little bit of the superior mesenteric artery we can see at this point. Okay, so the vessel below is the aorta, and vessel coming at this point here, the vessel coming is the superior mesenteric artery, and this is the celiac tract. So I think you are able to see in the longitudinal view all three arteries. Okay, so below is the aorta, this is the superior mesenteric, and at this point is not very clear because of this colon shadow. This is actually covered under this shadow, but here a little black shadow is moving up. Okay, so it is very difficult to see. You have to see through this acoustic shadow actually. So at this point, remaining the celiac tract. So let's try. We have now at this point, some gush of blood now moving up. Okay. So we can see only one part. Remember, we cannot see the right side. We can see only towards the hepatic part. In other side, there is a big gas shadow. Okay. So this portion is the turning point. So from here, the celiac trunk is moved up here and one branch is going to this side. Okay. So because the patient was fasting right now, where he has just taken a lot of food, so stomach is actually covered because of Ramadan. That's the problem today actually. So we cannot avoid him to take food, but you can see this portion. Okay. This is the common hepatic artery. And in right side, I will try to show you the other artery as well, but I am not sure because there is a big shadow there, the stomach. No. No, other side we won't be able to see, okay? Because in this side there is a huge gas shadow, okay? So under that gas shadow we cannot see. So one side I am able to find out. It is at this point, okay? So where we can see the artery moving up, but we can see only one side because in other side it is already covered. Just one right. Okay, so this side we can see. This is the aorta, this is the celiac tract, and from here this branch is going. But the other side we cannot see because of this shadow. Anyway, so but while doing the procedure, you prepare the patient well and go from this side to this side. Usually we prefer the liver and go at the top or just slightly above. You can go over the aorta as well. Okay. And then inject the neurolytic agent. Okay. Now coming to the next part, that is the superior mesenteric artery. Sorry, superior hypogastric. But mesenteric I have already shown. Superior hypogastric plexus. Superior hypogastric plexus is most of the time we found close to the umbilicus, though umbilicus is not a fixed point. So just go above the umbilicus and try to figure out the artery. So you can see the aorta at this point. Aorta is 1 now. Now, as I am seeing the aorta, I am putting the probe below. Now, as I am putting the probe below, now we can see aorta is divided into two branches. Okay, so we can see at this point, aorta is divided into two branches. Remember, it is not only the aorta, just by the side of the aorta, we can see a little bit of IVC shadows as well. Okay, not IVC, here it is divided. So as aorta is also divided, IVC is also being into the, okay. So at this point, what we see is known as the frog sign. So what is it? Now all the veins are blenched because of the pressure. But here we can see this is the L5 vertebral body. In one side, it is the right common iliac artery, and in the left side, it is the left common iliac artery. Under this view, we can from the left side or right side, just above the aorta, and then we can inject at this point. Okay. This is comparatively simple, but again, we'll need a little bit of bowel preparation also to avoid the infection as well. And also a little bit prophylactic antibiotic is given because there is no way if you're going from the anterior side, then you have to puncture the bowel. Okay. Any questions?
So would you mind kindly to just come back to the celiac?
Celiac is
Maybe you
difficult
mind this.
because
Sir, your
Yeah, it
preferred
wasn't
method
very
is
clear.
using fluoroscope or by ultrasound, sir?
Which one? What's the question? Just 1 minute. Scope, something endoscope.
I've asked if you could just try to show again, I mean, the celiac one, because it wasn't very clear.
Celiac one is you will not be able to see completely because
Okay.
one-sided shadow is there. So you try to figure out the aorta first, okay?
Okay.
Because left side is completely not visible. Only the right side, there is through a small window, it is visible right now.
So in patients also, it's same
In
thing.
patients also, sometimes it becomes unless and until there is a good bowel preparation, it is very difficult, okay?
In all the live workshops in
Now we can see the aorta, clearly aorta and IVC. Can you
Yeah.
appreciate the aorta and IVC?
Yeah, now we can see.
This is the aorta. This is the IVC.
Next,
Okay.
IVC.
This is the aorta. This is the IVC. This is the vertebral body. This is the aorta. Okay. My needle is just above the aorta. Now I will putting the angulation, because if I go down, it will come directly in front of the stool shadow. So right now I am changing the angulation slightly. So that is also hiding everything. Huh? So it is close to this area. Okay. So here at this point, we can see the, I am showing with color, otherwise it will feel more difficult. Too much of this stomach shadow covering everything here. Ah. Now here it is the area, okay, but here it is going under. Even now the stomach shadow has become bigger. So this is the area where it is dividing, but at this point the stomach shadow is just coming above it. Okay, now the best picture I can get is this one. So this, it is very difficult to figure out because everything becomes under the stomach shadow. This is the aorta and this is the artery. Okay, this is the common hepatic artery. The celiac trunk has gone under this shadow now. Okay, so a little bit difficult because today just he has taken a meal. Okay. But here from this picture you can appreciate where it would be. Okay.
Yeah.
Now it has become even worse. With the food, previously we can see the superior mesenteric artery. Now more everything become more blurred. Yes, a little bit. Aorta we can see. Superior mesenteric artery we can see now. From the aorta it is taking origin. This is the superior mesenteric artery. Okay. This is the aorta. This is the superior mesenteric artery from the aorta. And this is the celiac trunk. Okay. This is the celiac trunk. This side. This is the superior mesenteric artery. This is the aorta. Okay. But when we are seeing from that side, this shadow is covering everything actually. Okay. Today we will be able to demonstrate that much because there are a lot of food there. Okay. Move to the next topic.
okay. So someone was asking about what fluoroscopy guided and under ultrasound guided. Someone was asking, I could not understand the full question. But probably the question was difference between ultrasound guided or fluoroscopy guided. Actually, fluoroscopy guided you cannot do and from the anterior side. This celiac plexus neurolysis you cannot do anteriorly by fluoroscopy guided. It is fluoroscopy guided, it is always from posterior side. And with ultrasound guided, it is always from anterior side. And when to select what, if you are asking, then I will say that only few cases when bowel is good, well prepared, and if it is a thin patient, then we will go for the ultrasound guided. And if say patient cannot lie on the abdomen or anything like that, which is I mean positioning is also difficult, in that case only we will choose for the ultrasound guided. But many times ultrasound guided we do not see well, and patient also do not give us that position, then we will go for the CM guided procedure. Okay. Okay. And differences in ultrasound guided, the needle tip comes anterior to the aorta, exactly on the celiac plexus, whereas in X-ray guided, needle is a bit far, and the fluid or not the alcohol which we are injecting, that will actually diffuse to that point. Many times we are not reaching at that point. If it is transaortic, then you are going exactly at the area. Otherwise, the drug is diffusing from retrocrural area to the anterior to the aorta. Okay, and the place where the celiac plexus is there. Okay, then. So we are going to the next part. Okay, rest code. Okay. So let me talk about the next part of the topic. So we wanted to say we wanted to talk about the thoracic wall ultrasound and abdominal wall ultrasound. So here also only few things are important. Only few things are important in this thoracic wall and abdominal wall ultrasound, because most of the time the interventions which we do in the thoracic wall or abdominal wall area are actually important for regional anesthesia and not for chronic pain. But there are few small pain syndromes which are there, and we can few pain syndromes are there where we need this part of ultrasound also. So, like say, common causes of chest wall pain. One is post-herpetic neuralgia. One is thoracic radicular pain. So these can cause chest wall pain. So in post-herpetic neuralgia, of course, we can do intercostal nerve block, and otherwise also intercostal nerve other procedures like radiofrequency. Musculoskeletal, some causes like joints, costochondritis. Here, of course, it is the cartilage part of the rib which can be inflamed. So costochondritis or Titt's disease. Then come arthritis. So which joints? Manubriosternal joint or sternoclavicular joint, even xiphoidalgia. So these are some conditions where patient can have chest pain, chest wall pain mainly. Then comes fracture of rib, sternum or other cartilage unhealed. So rib fracture also can be going on, and then you can be doing this intercostal nerve block is possible. So other causes post-thoracotomy chest wall pain, scapulothoracic bursitis. So in every post-thoracotomy chest wall pain, of course, it is not the not that pain intervention will work, but in some cases where it is a scar neuralgia, then some intervention can be done in the scar. Then comes post scapulothoracic bursitis or snapping scapula syndrome. So it is a specific bursa which is just found under the scapula and over the ribs, over the thoracic cage and under the scapula. But then in a normal volunteer, we do not see anything. If there is a bursa, then only we can see under the ultrasound or under CT scan, we can see bursal fluid there. So scapulothoracic bursitis is sometimes possible. Sleeping rib syndrome, that is under the subcostal area, under the 12th rib, 11th rib, these areas can cause the chest pain by sleeping rib syndrome. Other referred pain can be there in the chest: fibromyalgia, Mondor's disease, bony metastasis, sickle cell crisis. All these things can cause chest wall pain. Now, in postoperative herpetic neuralgia, you can see this type of areas, healed rash. Rash was there, but now it is healed, but still patient is having too much pain. So what can you do? You can do some intercostal nerve block. Epidural steroid injections also can be given, or intrathecal pump therapy or other options are there. Of course, post-herpetic neuralgia treatments are not very successful. That's why we go for multiple type of treatment. Thoracic radicular pain, as we know, thoracic epidural steroid injection can be given, intercostal nerve block also can be tried, and radiofrequency ablation can be done. Of course, radiofrequency ablation in these cases, actually blocks are more important than radiofrequency ablation, because if you do a radiofrequency ablation of the intercostal nerve block, this happened with us actually, that there was atrophy of the muscle, and then there was a hernia. So you cannot ablate the nerve, because this supplies the muscle bulk also. So it is more often the block, it works for some time, or then this one, pulse radio frequency, you can go for it. And of course, it will give you a temporary relief, but it is better than something is better than nothing, because many other drugs do not work at all. So if you give a intercostal nerve block, and if it works for a few months, then also patient is happy. Then comes costochondritis. So steroid injection can be given at the costochondral junctions, and yeah, of course, for diagnostic purpose also it is very important. Many times it is confused with the heart pain, or say different other visceral pain. So if you just give a local anesthetic as a diagnostic block, and immediately pain just vanishes, then you know that it is from the costochondral junction only. And this is not very uncommon. Many times with this type of chest pain, patient comes from cardiologist. Cardiologists also sometimes they refer. They say to the patient that your pain is not from cardiac origin, and when they reach to you, you have to go for something like a diagnostic block, so that if patient pain vanishes, then only patient will believe you. Otherwise, they are convinced that maybe they are having a big disease. Now come the bony metastasis. So there are different bony metastasis to the ribs is very common, and so that also can be very much painful. So post thoracotomy pain syndrome, as I told you, that it can have multiple different reasons. So post thoracotomy pain syndrome treatments are different for different spread of the pain. If it is in the anterior side, so different procedure. If it is in the posterior side, also so different procedure. So now let us talk about some anatomy part, because we need to know the muscles of the thoracic region. Okay, so here you can see one important thing. So costochondral junction, you can see. So these areas are for costochondritis. You should be able to find out the costochondral junction to see if there is a reason for costochondritis under ultrasound. And here you can see up to 7th rib, it is directly these ribs are attached to the cartilage, and it is going to the it is a connection with the sternum. But after that, 8th, 9th, 10th, 11th ribs, so these ribs are not directly ribs are not directly connected to the sternum, and they are connected with each other. So in these areas, sleeping rib syndrome is very much common and can cause these areas painful. Then comes, so here what are the muscles, intercostal muscles? So we know that external intercostal, internal intercostal, and innermost intercostal. So these three muscles we will see always between the ribs, and we should know that this nerve fiber, this intercostal nerve lies between two muscle layers. That is internal intercostal and innermost intercostal. These two, between these two layers, it is the layer for intercostal nerve. And from the intercostal nerve, cutaneous branches arises. So one is lateral cutaneous branch, one is anterior cutaneous branch. So in this, when we are targeting the intercostal nerves, we are targeting proximal to the lateral cutaneous branch, not after that. So we will target in the mid axillary line or posterior axillary line here. Then comes nerves. So there are multiple nerves in the thorax region. So here already I told you this part, that lateral, this one, your anterior cutaneous nerve and lateral cutaneous nerve. This cutaneous, before that cutaneous nerves comes out in the from the intercostal nerve, there we go for the intercostal nerve block. Okay. Then comes here, there are some nerves in the thorax region. So if you remember the brachial plexus, so brachial plexus, we know that roots, trunks, divisions, and cords. So in this way, if we think about the brachial plexus, so there are some nerves. One nerve comes from the root region. So that is long thoracic nerve. So these long thoracic nerve, though these are not sensory nerves, these are all motor nerves, but there can be some these nerves also can cause some pulses, actually motor nerve pulses. So in that case, we can go for hydrodissection of these nerves, or at least for other procedures also we should be knowing that where these nerves are, where we can find these nerves. So one is long thoracic nerve, so that we do not puncture them or do not traumatize them for while doing the other procedures. So one is long thoracic nerve. And here in the cord region, you can see lateral pectoral nerve, medial pectoral nerve, and thoracodorsal nerve. So three nerves are there. Remember, in the axillary region, there are two nerves. One is long thoracic nerve, which is coming from the root region. One is thoracodorsal nerve, which is coming from the cord region. It is in the axillary region. And in the front side of the chest, there are two nerves, that is medial pectoral nerve and lateral pectoral nerve. Okay. So two nerves in the front side of the chest and two nerves in the lateral side or axillary region. And so these four nerves are there in front of the chest, and they are all accompanied by some vessels. So long thoracic nerve accompanied by lateral thoracic artery. Okay, and long thoracic by here it is small written lateral thoracic artery, and thoracodorsal nerve accompanied by thoracodorsal artery, whereas medial pectoral nerve and lateral pectoral nerve also supplied by medial pectoral and lateral pectoral arteries. Okay. Here you can, this is the pectoral branches. So pectoral branches are there. Remember, when we see the front side of the chest, between pectoralis major and minor, we find the lateral pectoral artery, whereas pectoralis, under the pectoralis minor, it is the medial pectoral artery. Okay. Now demonstration wise, when we want to see the chest wall from the front side, then the patient can be lying down in this way, or patient can be sitting. Okay, patient can be sitting, even patient can be lying in one side up. So that is also possible to see the chest wall from that side. Okay, and we will most of the time use the linear probe. Only in few areas we need curvilinear probe. Otherwise, we need only the linear probe is sufficient for seeing the chest wall. If patient is not too much heavy, then when I will show you, so just I show you the pictures. So these are important for our as a pain physician. So one is to understand where can we go for the intercostal nerve block. Then we will see where we can find the lateral and medial pectoral nerve. We will also see the long thoracic nerve and thoracodorsal nerve. costochondral joint, sternoclavicular joint, these also we will see. Now comes, so this is the picture for intercostal nerves. So this part I will show you. So and just try to see that both ribs when we will see. So we can see that the vessels and neurovascular bundle, the whole neurovascular bundle is actually just below the lower border of the upper rib, and it is between the innermost internal intercostal and innermost intercostal. Okay, so we can see by color. So when we go for a block, the intercostal nerve block, remember after giving fluid or local anesthetic, or after injecting the local anesthetic, the anesthetic should press the pleura, and not the upper muscles above. So that causes the incorrect procedure. That means you are not in the right place. You are actually injecting in the either in the intercostal internal intercostal muscle or in the external intercostal muscle. But if you are below internal intercostal muscle, so in that area if you inject, so below that it is only the membrane, so the fluid will of course press the pleura only, and that is the correct procedure. So peristernal block and all these we are not showing you, but these sometimes can be important for regional anesthesia part. There we can see just by the side of the sternum, we can see these internal mammary vessels. Anyway, so pectoral nerves, where are the pectoral nerves? So between pectoralis major and minor. So here upper one major, lower one minor. So between major and minor, we will see lateral pectoral artery. Lateral pectoral artery and associated nerve. Artery is more easily seen, nerve is not easily seen because it is very tiny nerve. So these are all like plain blocks. If you want to block, then if you inject in the plane, just by the side of the artery, that nerve is also blocked. Then where is the medial pectoral nerve? So that is below pectoralis minor. Below pectoralis minor, so artery you will see and you can block. There are we can see in these areas there are some serratus anterior block. So this I'm not showing you, but just to tell you that the muscles or areas. So pectoralis major, minor. If you connect from left this picture from this picture when you are going down gradually. So this starts from the second rib. Then as soon as you come over the fourth rib, you see that pectoralis major, minor, and below that another muscle starts. That is the serratus anterior muscle. So there are PEC1, PEC2 blocks. You can go for between the pectoralis major, minor, or below the pectoralis minor, serratus anterior. So these blocks are for different regional anesthesias. Okay. Now comes, so these are I'm not showing. Now, okay, so this one is no, this one is long thoracic nerve. So I will show you the long thoracic nerve. So remember, long thoracic nerve and thoracodorsal nerve. These two, if I just show you one anatomy picture, you will understand. Okay. So just see in anatomically, if you see one side from one side, so that is I think yes. So from one side, so this is the serratus anterior. This is the this area is serratus anterior. So here from anteriorly, if you see, there is only one muscle, that is pectoralis major. So in the anterior side, this is pectoralis major, and just below that, that is serratus anterior. That is serratus anterior. If you remove the serratus anterior, then it directly bone comes, nothing else. Okay. And here also in the posterior side, so here also serratus anterior is there, and just above that only one muscle is there, that is the latissimus dorsi. So in the axilla area, it is just the serratus anterior, which is covered by anteriorly pectoralis major and posteriorly by latissimus dorsi. So remember, if I come from pectoralis major side and I enter, my probe comes over the serratus anterior. So at some point there will be I will see the edge of this pectoralis major. At the edge, I can see the long thoracic nerve with the lateral thoracic artery. So I will mainly see the vessels, sometimes nerve is also seen. So at this point, I can see the long thoracic nerve with lateral thoracic artery. And as soon as again I go at the junction between the lateral latissimus dorsi and serratus anterior, so at that point I will see another vessel, which is vessel and nerve, that is the thoracodorsal artery at nerve. So these are the locations of finding these nerves and arteries. Okay. So Tidd syndrome, as I told you. So this is the Tidd syndrome. So this is the cross section of this one, your cartilage. So cartilage is anechoic, like any fluid. So this is a anechoic fluid like. So when there is a problem in the cartilage, like inflammation, then not only the Doppler signal will increase, it will become a bit hazy also. And if you see in this view, it will become a bit thicker cartilage, some swelling you can see. So that also tells you. So here in the left side, it is a bit hazy, and this becomes a bit thicker also. So this side, of course, this side is a bit thicker. So this tells us that it is a costochondritis. And sternocostal junction and all. So you can see the junction. Of course, if there is osteoarthritic change, then that will be evident. If it is not there, then of course you have to put the vascular, Doppler, to see increased signal or not. Okay, you can do the procedure in the sternoclavicular joint or this one, in the sternoclavicular joint, you can go for, or sternocostal joint, you can do the procedure under ultrasound. So this is good for localizing the joint. Okay, this is good for localizing the. Here you can see this is the osteoarthritic joint, sternum plus clavicle. So this is like irregularity on the bony surface, and of course there is some swelling of the joint capsule. Okay. So manubriosternal joint arthritis also can be seen. Dorsal scapular nerve, as I told you, so here in the posterior side, there are few muscles. So this picture also I didn't show you. Just a minute. I show you this picture. It is better. Otherwise, you will not be able to understand. Okay. So this is the. So in this picture, so you can see this is the what muscle? This is the trapezius. So if I hide it, so just understand that trapezius, if I consider it in the first layer, trapezius, and this is the latissimus dorsi. So this is first layer. Okay, I am not hiding it. This is first layer. So what is the second layer? Second layer is okay. So what is the second layer? Second layer is this one, levator scapulae, rhomboid, levator scapulae, and rhomboid minor and rhomboid major. Though the first is most cranial is levator scapulae, then rhomboid minor, then rhomboid major. But all are second layer. Okay, all are second layer. So just remember this. The first layer was trapezius, second layer was levator scapulae, then rhomboid minor and rhomboid major. Then third layer was serratus posterior height. So, and after that, of course, you will see the other muscles like spinalis, cervicis, and all. So these are your paraspinal muscles, and then below that, if you see in this area, of course, you will see the all intercostal muscles. Then you will see the intercostal muscles in the deeper layer, in the deeper layer. So mainly in this area, just by the side of the medial to the scapular margin, you are seeing 3 layers. Okay, so why it is important here? So you will get some patients, those who have chronic neck pain, and you will see that muscle has multiple trigger points. So it has been seen that it is not only the muscle, the fascia between, they are also very much important for the overlying muscle to contract or remain contracted for a long time, chronic contraction. So one procedure has been suggested, that is 5-in-1 block. So 5-in-1 block, what we do, we inject trigger point injection in the trapezius and below in the levator scapulae, and then below in the second layer only rhomboid minor or major. There are also three muscles injection in the trigger point injection, and 2 nerves. One nerve is between layer 1 and 2, that is below between trapezius, and second layer means levator scapulae. Between these 2 layers, nerve found is spinal accessory nerve, so we'll inject there. And another nerve which is below levator scapulae. Okay, so below levator scapulae and serratus anterior, so serratus posterior superior actually, so mainly below levator scapulae. Sometimes it is below rhomboids also, because it is second layer. So that is another nerve, that is the dorsal scapular nerve. So in these 2 nerves we will do hydrodissection, and these 3 muscles, you remember, trapezius, levator scapulae, rhomboids. So these 3 muscles will give trigger point injection. So that is the treatment for the chronic myofascial pain syndrome of the upper back, okay, or say posterior part of the neck. So this is a so this is the I will show you the areas where to inject. So scapulothoracic bursitis, as I said, if you can see, I mean, if you see there is a bursitis, then of course you will see this type of fluid collection and all. But in general, in volunteer, there is nothing to see. Abdominal wall ultrasound. So there are only 4 nerves: ilioinguinal nerve, iliohypogastric nerve, genitofemoral nerve, lateral femoral cutaneous nerve. Genitofemoral and lateral femoral cutaneous nerve we show with the hip ultrasound. So here I will not show, only the ilioinguinal and iliohypogastric I will show. So here abdominal cutaneous nerve entrapment syndrome. So that is also like anterior cutaneous nerves, you can understand. So intercostal nerve, if you remember, then it gives branches, anterior cutaneous nerves and lateral cutaneous nerves. So this is a syndrome, anterior cutaneous nerve entrapment syndrome. Coronet sign is one clinical examination, so for diagnosing it. But for your intervention, you have to go for the plane between the tap block plane. Okay, so we will see the in that plane only we will find these nerves also, your ilioinguinal and iliohypogastric. So you can see ilioinguinal, iliohypogastric, it is from the lumbar plexus, and ultimately this is also in the same plane. So this is the lumbosacral plexus, and so in the lumbar plexus we see these 2 nerves are mainly in this plane of internal oblique and transversus abdominis. So we find these two nerves, and we can go for a block there. Okay, and they are also supplied by vessels. They are also supplied by different vessels. Okay. So okay, I'm not going into these things. Okay. So lastly, counting the level. So when you do thoracic wall ultrasound, we should know how to count the levels. But of course, this counting of the thing I show in the thoracic thoracic spine ultrasound. Always I show this. So, okay, I just start showing the ultrasound, otherwise I will be very late. So if someone has any question, please ask me, and I will be showing, I will be telling while demonstrating. So first thing, let me show you the abdomen. Let me start with the abdominal ultrasound. No. Okay. So here, what I first want to see, I will start from the midline. I will start from the midline here. Okay. So what I can see here, I'm starting from the midline.
On the volunteer is not working.
Yes.
The camera on volunteer is not working.
Camera not what? Oh, okay. Yeah, that's right. Okay, now it's working. Now it's working. Okay. So what I am showing here. So this is the midline of abdomen above the umbilicus. I'm just putting it in a short axis manner. Okay, transversely. So here, what is this? This is some fat. Okay, this is some fat. This part is nothing but linea alba. Linea alba. What is this muscle? Anybody can say. Let me see that whether you can understand or not. What is this muscle?
Rectus abdominis.
Rectus abdominis. Now I'm going laterally. What is this line called? Since this is linea alba, just between these two rectus abdominis. Now I'm going laterally. This is rectus abdominis. If the finished, rectus abdominis finished. What is this line called? Linea semilunaris. Okay, linea semilunaris. Now I'm going laterally. What is the upper muscle? This one?
External oblique.
Yes. Then middle, internal oblique,
Transverse
transversus abdominis. Now I am going laterally, but I'm after going some area, I will go towards the anterior superior iliac spine. I am going towards the anterior superior iliac spine. Okay. Just a minute. Okay. So these are the three muscles. I am going towards the anterior superior iliac spine. So I can see the bone. So this is the anterior superior iliac spine. This is the anterior superior iliac spine. Bony shadow is there. Bony shadow. So at this point, my probe is actually looking towards the umbilicus. One side anterior superior iliac spine, one side it is towards the umbilicus. Here three muscle layer already we know. Why I have not started from here? Because sometimes here external oblique is not seen well, because it is already over here. Somebody can start from here and can find that okay, there are only two layers. So I start from the umbilicus and then I come. So here three layers are there, and then this area. Okay, this area. So here I can see between the, if I decrease the depth a bit, yeah. So this is the, so you can see some vessel and some nerves here. So here in this area, some neurovascular bundle is there between the internal oblique and transversus abdominis, this area. Okay, and if we see more carefully, here also some bundle is there. Here one bundle, here one bundle. So what are these nerves?
Ilioinguinal and iliohypogastric.
Yes, ilioinguinal and iliohypogastric. These two nerves are there, and these are all the peritoneum shadow and all. So you can go for ilioinguinal and iliohypogastric nerve block here in these areas. So these are plain block. Directly we cannot, we do not see the vessels, nerves. Directly we do not see the nerves. These are very small nerves, but we can see the accompanying vessels. So these are, you can inject here. Okay, so this is one thing. Now in abdomen, nothing more. Yeah, in abdomen, nothing more. I will go in the chest part.
It's an anterior cutaneous branch where we have to locate. See.
Anterior cutaneous branch, I mean, you cannot locate the anterior cutaneous branch. Only the, if it is a anterior cutaneous nerve syndrome, then you can anterior cutaneous nerve entrapment syndrome. In that case, you will go for TAP block. TAP block means it is similar, I mean, normal to our any regional anesthesia. So in this plane, you will go for between the internal oblique and transversus abdominis. You cannot see this cutaneous nerve. This is so small. Okay, you cannot see.
Okay, sir.
Okay, so এটা উঠা তাড়াতাড়ি কর তো কে দেখছে হ্যাঁ কি দেখছেটা কি মুখ দেখা যাচ্ছে না okay so our volunteer is very shy. It's a big problem. So anyway, so now what we are showing is, so here what I am seeing is actually sternum. It is the sternum. It is the sternum. So if I come to one side, then suddenly I will see these round things. Okay, so what are these things? These round things, black round shadows. What are these things?
Yeah, the ribs.
Ribs.
Not
Yeah,
ribs. Rib is a bone.
Oh.
You cannot see below rib, below bone. Our ultrasound do not puncture, go through the bone. So these are chondro, cartilage part. Okay, these round things are cartilage part. Okay, as soon as we will go, so till now it is cartilage. Now bone. So as soon as you see the bone, you cannot see the, it will be acoustic shadow. Okay, it is acoustic shadow. Now cartilage. This much is cartilage. Okay, so you can see it in a long axis also. So you see like this. So remember, you have to be in the same plane. You have to be same plane. So sternum is a bone. So you can see the sternum in the midline. So this is sternum. You can see the cartilage. So this is cartilage. Below cartilage, you will of course see the pleura. Below cartilage. Suddenly in this area, you see that you do not see the pleura, because it is bone has started. So where is the costochondral junction? This is the costochondral junction. So at this area, someone can tell you that my pain is here. So whether it is costochondritis or not, you can understand. Whether if you give Doppler, you can see that whether it is a case of costochondritis or not. Okay, more vascularity is there or not. So just understand that in this way we can understand that where is the costochondral junction. And secondly, when I am seeing these cartilages in this way, then you can compare with the adjacent cartilage or the opposite cartilage, that all cartilages are looking similar or not. Mainly it is better to compare with the opposite cartilage. Suddenly one cartilage may look a bit bigger, okay, a bit bigger. And actually while telling, I told the opposite thing. It should be a bit bigger, and since it is edematous and more fluid comes, it becomes more dark. Okay, more anechoic type. This is the normal picture, but when it is edematous, it is the more anechoic type and swollen. Okay, so that is how you know that it is costochondritis or not. Okay, now comes so other joints are like sternoclavicular joint. So sternoclavicular joint is nothing big. So this is the sternoclavicular joint. So this is the sternoclavicular joint. So this is you can palpate and see. So this is a sternoclavicular joint. So if he is not saying that he has any pain or say this is normal sternoclavicular joint because capsule is not swollen capsule or bulged capsule. There is no fluid collection and this is the normal sternoclavicular joint. Okay. So manubriosternal joint is not very clearly seen. It is very difficult to see. So this is the manubriosternal. At least in this volunteer, at least we can see, but in some volunteer we cannot see because it becomes a completely fused joint. So this is a manubriosternal joint. Okay. So this is a manubriosternal joint. Okay. Now let me show you some other. So if I just put the probe like this, here left side is cranial side, left side is cranial side. So here, so just I am putting the probe like this. So here, can you tell me that which muscle is this? This one, upper one. Arrow, this one, which muscle is this?
Major.
Yes, pectoralis major. So which muscle is this?
Pectoralis minor.
Minor, yes. So if I do like this, then between pectoralis major and minor, what I expect to see? No.
Long thoracic.
No. Between pectoralis and major and minor, I expect to see lateral pectoral nerve.
Sorry, lateral.
So let me see if I can see or not. So this actually it is getting compressed. Okay, you see with your eye. It is not taking color, but here there is some vessels. Okay, at present I am seeing this vessel better. Okay, so what is this? This is this vessel better. Okay, so this vessel is nothing but which vessel? Below pectoralis minor. So which vessel is this?
Medial
Okay.
pectoral.
Yes, this is medial pectoral. So below pectoralis minor, this is medial pectoral. And between pectoralis major and minor, we will see the lateral pectoral. So lateral pectoral is between, it is not very tough to see. It is very easy to see. Here, of course, somehow, okay, this part. So you see here, there is one vessel. It is not evident, but so here, this is the medial pectoral. This is the medial pectoral. Above, actually, in this plane, there is a lateral pectoral. So anyway, so this is the area for. So here it is, the vessel is there. Here vessel is there, but somehow I am not being able to locate it. So this one is the vessel. So we understood that this is pectoralis major and minor, and between in these two layers we can see the vessels. Now, so here one more thing, when we just go up and up, So as soon as we see the vessels, these are the vessels. So what vessels are there? These vessels? Anyone can say what vessels are these?
Subclavian.
Eh?
Subclavian, sir.
Yes, okay. Subclavian, axillary, yeah.
Axillary, yeah.
Axillary
Axillary.
actually, they has come. So if this is axillary, oh, what is this then? This part, just a minute, just below the, just a minute. বাবা, একটু এদিকে আয় তো, এদিকে আয়, এদিকে আয়। বাবা, আমার অবস্থা শেষ, কোমর ব্যথা হয়ে গেল। So, if this is axillary, so if this is axillary, then here there is a rib. You can understand. I think this is a rib. Shadow is there. See. So which rib is this? Just by the side of the axillary. This rib. Anyone have the idea? What is the rib? Now you see between pectoralis major and minor, this vessel is seen so clearly. Now this vessel is normal. So just by the side of the axillary vessels, this rib is second rib. Okay. If I go down, this is third rib. This is pleura. Okay. If I go down, this is fourth rib. Fourth rib. So here in the fourth rib area, in the fourth rib area, so here there is, oh, so okay, so this is the fourth rib. So here one more muscle is coming. This muscle, if I decrease the depth a bit, okay, this muscle we can see, this muscle. So what is this muscle? This muscle, anyone can understand? This is pectoralis major, this is minor, and in this area,
Serratus anterior.
yes. So if I go a bit in the axillary side, then this pectoralis major minor is nothing is there. Okay, only the serratus anterior. So this part I showed you in picture, that in this area nothing is there. In the 3D picture I showed you. So only serratus anterior. And in one side above serratus anterior there will be pectoralis major minor, and in another side if I go down posteriorly, then it will be covered by the latissimus dorsi. So here, after understanding that this is serratus anterior, I am moving it like this, okay, I have moved it. So you can understand that if this is the middle part just over the rib, this is the serratus anterior, then what is in the right side? It is the pectoralis major minor, isn't it? You can see the muscles. This is pectoralis major, this is minor, and this is the serratus anterior. Third one is serratus anterior. Three groups are there. So 1, 2, and this 3. So this serratus anterior and the pectoralis major minor. In this area, if I go up and down, I will be able to see one vessel. Can you see the vessel? Can you see this vessel, which is below pectoralis major minor but above serratus anterior? Can you see? So this vessel is nothing but the long lateral thoracic artery. This is the lateral thoracic artery and accompanied by the long thoracic nerve. Okay, so this is the location. This is the location of just above the serratus anterior. So this one is the above the serratus anterior but under the pectoralis major minor. So this is the area where long thoracic artery and long thoracic nerve, lateral thoracic artery accompanied. Now if I go posteriorly, so একটু ঘুরতে দেখি একটু এরকম কর। Okay. So I'm making him rotate. So you can, why I'm showing you these muscles, because just to understand that, just to understand the muscles orientation. Okay, because sometimes in some disease, it can be important. Okay, so here already I showed you. So this part. Okay, he moved a bit, so I can see from here. So this is the area where we found the long thoracic artery, or long thoracic nerve, lateral thoracic artery between this one. Now, if I just go in the posterior side, then this is the latissimus dorsi, and it is covering the serratus anterior. So in this area, of course, I will be able to see the another vessel. So this is another vessel. Okay, this small vessel. So this is the dorsal scapular, not dorsal scapular. This one. So which vessel is this? This one. Thoracodorsal. So this one, you can see. So this is the only muscle. This is the latissimus dorsi, and this from posterior side. This is the latissimus dorsi. This is the serratus posterior. Serratus anterior. Serratus anterior, latissimus dorsi, and this is the thoracodorsal artery. Of course, accompanied by thoracodorsal nerve. So this is the location of the thoracodorsal artery. Okay. So this is just to show you the areas where the arteries and different arteries are there. Now, lastly, I show you the 5-in-1 block, which is important for the shoulder pain. बस बस ठीक है Okay, so so I'm showing you the, so say this patient has a chronic trapezius area pain, chronic neck pain. So this patient can have a myofascial pain syndrome of the neck, and you can go for 5-in-1 injection. So you have to understand what are the muscles at which area. So this is the scapular spine. We can see the scapular spine. So above that, what muscle is there? There is trapezius and supraspinatus. So I will start from there. Okay, so first muscle is trapezius. So here left side of your screen is nothing but the medial side. Okay, left side of the screen is medial side, and right side is lateral side. So here first layer, what is this first layer? This is the trapezius, and this is the supraspinatus, and this is the scapular bone, supraspinatus fossa, not the scapular spine. But here, when I am seeing laterally, as I am going laterally, so what I can see? I can see one small muscle, triangular muscle. Okay, so this triangular muscle is which muscle? Anyone can say?
Levator scapula.
Levator scapulae. This is the levator scapulae. Okay. So if this is the levator scapulae, then we can see one vessel below the levator scapulae. Here. So this is the dorsal scapular artery. And here, many times we can see the dorsal scapular nerve even. Okay. Here, of course, today I can see or not, but many times we can see. So we can see the vessel very nicely. We can see the vessel very nicely, and it is associated with dorsal scapular nerve. So this is one important thing. So this is one plane. Okay, just above that, this was the levator scapulae. Above that, this is the trapezius. Okay, here, if I ask you, what are these muscles? What are these muscles? Anyone can say what is these muscles?
Serratus posterior.
No,
Rhomboides.
no.
No.
These are intercostal muscles. Why? You are seeing the pleura. Okay, and just above the pleura, these are intercostal muscle. If I go just above or below, as soon as you see the rib, so this is the rib. Okay, and just in the intercostal space, you are seeing the intercostal muscles, and this is the rib. So all other three groups of muscles should be above this rib level. Okay, not below this. So this part you must understand. This is the pleura. While doing any procedure, you must not go too deep to puncture the pleura. This is not the third muscle group. This is the intercostal muscles. So above that, so this part is for second group. This is here in the right side, it is the levator scapulae. Left side, it is the rhomboids. And the serratus posterior superior is here. It is a very thin muscle. It is a very thin muscle. It is here. And as I told you, there is another nerve which is the spinal accessory nerve that is between the first and second layer. So this is trapezius, this is second layer. And here you see one more vessel. So this vessel is also this is a cervical transverse cervical artery. This is called transverse cervical artery. So this also accompanies the spinal accessory nerve. But spinal accessory nerve, as such, we cannot identify the spinal accessory nerve. So remember, we will go for hydrodissection of the spinal accessory nerve here for between this first and second layer. One is trapezius, one is levator scapulae. And we will go for hydrodissection of the dorsal scapular nerve between levator scapulae and the third layer is not there, but here just below the levator scapulae. Okay, so this is the dorsal scapular artery and associated dorsal scapular vessels. Okay, third layer is very thin actually. This is the third layer, serratus posterior superior. Now, so this one. So this is thin third layer. Okay, this is the thin third layer over the rib, you can see. Now you can sometimes get confused that which one is rhomboids and which one is levator scapulae. Understand, this levator scapulae is this much only, this triangle, and rhomboids is in this side. These are second layer, but these are rhomboids. There is another way to understand the rhomboids. So in this area, when we are seeing the thoracic paraspinal muscles, just a minute. This is the thoracic paraspinal muscles. So here, remember, if I need to increase the depth a bit, so here in the thoracic paraspinal muscles. So here, so here, this is the thoracic paraspinal muscles, and you will see, so this is the thoracic paraspinal muscles. When you come down like this, from cranial to caudal, when you come down, suddenly you see one muscle group that is gradually, it takes a conical shape. It takes a conical shape and it vanishes. Okay, so that muscle here, so this second layer of muscle, this muscle, Okay, so remember this muscle, it is like comes up to a limit and then it is vanished. It doesn't come very long. Just wait. Is wait a minute. Just a minute. No. So this is the triangular muscle, and just by the triangular muscle, this is the trapezius. And if I just hold like this, so this area, so this second layer of muscles, if you just in the thoracic area, if you just hold in this way, then one muscle it tapers off gradually. It tapers off. So this is first layer, this is second layer, this is third layer. This tapering of the muscle, this is nothing but the rhomboids muscle. This is nothing but the rhomboid group. Okay, this tapering is very evident. So other two muscles remain parallel, but one muscle from cranial to caudal, it starts tapering. Okay, so this muscle only, it is the rhomboid muscle. Okay. So this is the 5-in-1 5-in-1 injection. So when we go for this myofascial neck pain. So is there any question here? Is there any question? So in thoracic area, nothing more. And intercostal nerve block, I did not show you here because we always show during the thoracic spine ultrasound, intercostal nerve block. Okay. You can hear me, no? Clearly?
Yes, sir.
Okay. So if there is no question, okay, then today, okay, good night then. Today we'll not go for this quiz.com. It is already 7:45. So, okay then, good night.
Good night, sir.